Previously on JSpeaks.
We're wired to track danger. And one of the biggest dangers we face, and we don't realize this, most of us don't realize this on a day-to-day basis, is the disconnection of our relationships. Our survival as a human species depended upon our bonds together. We're just these, imagine just evolving and we got these big brains, but we're these just weird naked apes running around with like not any defenses on our body. We had to stick together. So that's why when you experience stress in a relationship, your body freaks out. You get upset, you get triggered. And the trigger is like, get that bond back in place. Only problem is, people have certainties, right? They have certainties and they want to say, you got to do it this way, or you got to see it my way. And the problem is really this. And the other person goes, no, it's actually this. So what am I saying? There's a long-winded way of saying is the problem is the attempted solutions. It's the dialogue about it. And then once that dialogue happens, it can leave people experiencing more and more of a sense of distance. So then you have the elephant in the room. You have the thing that the family avoids because talking about it just felt so unsuccessful, can we really blame anyone? If it hurts, if it doesn't solve anything to talk about it, we gotta stuff it away. But sad thing is it doesn't get solved. It just lives there.
Check out today, Restore Family Connection through Emotionally Focused Therapy.
Hello everyone. For those of you who are new to my channel, welcome. And for those of you who are subscribed to JSpeaks, thank you so much and welcome back. As you know, it is my mission, it is my passion to bring to you all conversation topics that are positive, motivational, educational, and informational. Ladies and gentlemen, today I am so excited to be here with Dr. Tanya Bass. Dr. Bass is an award-winning sexuality educator and mental health advocate who is committed to advancing health equity through culturally responsive and inclusive professional development. Dr. Bass is also the founder of NC's SexCon, where she uses her talents, skills, and energies as a certified health educator, as a certified sexuality educator, and equity manager to efficiently and effectively provide leadership and develop strategies to help the organization's equity programs grow. Please sit back, relax, and most importantly, listen. And hopefully after today's episode, you have a better understanding as to why the subject of health equity should be important to you. So Dr. Bass, it's truly a pleasure to be with you right now. Before we get started, I feel as though it would be appropriate if you could just share a little bit about yourself. Who is Dr. Bass?
Sure, it's a pleasure to be here with you as well. So if I were to share who I am, I guess I would say I am a Southern transplant, originally born in Brooklyn, New York. I'm a public health educator, I'm a sexuality educator, I'm a Black female, and just love doing human service work. And thinking about my career, just working in public health, and then diving into sexual and reproductive health, and really embracing opportunities to expand health equity.
Nice, nice. So you're a long way from Brooklyn. What brought you down here?
Absolutely. So my family is originally from Eastern North Carolina, the 252 area, Beaufort County. Shout out to the 252. And when my mother was young, she actually moved to Brooklyn with my grandmother. And then we used to come down south all the time. And so I love being in North Carolina. And when my grandmother said she was going to retire, I said, hey, I'm going to go with you. And she said, I've raised all my kids. So she said, you're not going to be able to come. But she actually allowed me to come. And I stayed here ever since and fell in love with the state. So I've been here since age 12.
Nice, nice. And I've been here for about 3 years now, and I love it here.
Good.
It has everything. It has, you know, the slow pace, kind people, um, just just a peaceful, tranquil state.
It is.
It's where, you know, the Northerners come to slow down and the provincial Southerners come to just speed up a little bit.
A little bit,
It's nice.
yeah.
So getting into the conversation of health equity,
Okay.
I believe that the first question that I want to ask, I feel as though all of my viewers are wondering the same thing. You know, what does health equity mean? Is the subject, is the topic of health equity, is it new? Could you please explain that?
Absolutely. So I started my career and work and um, thinking about health equity and public health in general as an undergraduate here at North Carolina Central University in Durham, North Carolina. And as I think about health equity, I don't think it's new. I think we're using new terminology. So probably since the late 80s, there was actually a report called the Heckler Report that showed that there was disparate rates of health conditions between the Black community and the general population or white community. And so with that report, we established, or the US government established, offices of minority health. And it was really to focus on how do we fill those gaps or improve the health of African Americans in comparison to, which made that the standard, like white health. And so from that time, I think the work has progressed. I think we've been more thoughtful over time about like what are some of the issues that actually cause these disparities. So it's not so much that communities of color or African Americans are so prone to disease, but what are the systems, what are some of the policies, and what are some of even the historical factors that make these conditions more prevalent in our communities. So as a student here at NCCU, I remember working on what they called then the Healthy People 2000. And as a public health education major, I was thinking, man, I got to do all this work, and maybe in the year 2000, I'm not going to have a job because we're going to fix everything and everyone is going to have good health. And that probably was a little naive and a little ambitious, but we did make some strides in looking at improving health, because health equity is about ensuring all people, regardless of who they are, their social identities, where they live, their educational status, that they have the opportunity to experience good health. And that's what Healthy People 2000 was seeking to do, but there still were gaps in that. So then as years went on, we had Healthy People 2010, 2020, and now we're moving into Healthy People 2030, and we still haven't realized health equity. We're making changes in policies. We're understanding some of the root causes, which includes racism and systemic oppression, but yet there's still these mindsets of providers, whether in the medical industry or in public health, that don't look at policies to ensure that they're equitable for everybody.
And why is that?
I think a lot of it has to do with lack of knowledge and power and control. So if you think about where folks have to go to receive their medical care, that is embodied in the system. And people often talk about the system is broken, but what they don't often look at is the system is managed by the people. So it's not the system itself, it's the people who are in control of the system. And typically those systems are operated by people in power and who have an advantage or more power or privilege than the marginalized communities in which they typically serve. So if you think about a hospital community, the power is going to lie within the hospital. Ideally, like, and I say ideally, I think it's more like maybe imagined power. Like there's a level of wealth that we see. So health equity is also about social justice. And so we see that power from a social perspective, but we know that people have power collectively. But oftentimes the people don't realize how much power they have to upset these systems. So I think that's part of I think one of the biggest causes is the historical injustices that still play out in our laws and policies, and then the systems that exist that are actually navigated and managed by people in positions of power.
Interesting, interesting. So you mentioned, you know, racism being a huge barrier. Could we talk a little bit more about that, and
Sure.
also some more barriers when it comes to health equity as well?
Absolutely. So a lot of my work, especially around health equity, looks at sexual health, for example. If we think about even challenges with reproductive health, reproductive justice and reproductive laws, if we look at even for an example around maternal mortality, Serena Williams. So there's this idea that's been historical that Black women in particular can actually take more pain, right? They can handle more pain, or they don't need more medication. Or there's this idea around racism that they may not need medication even for that pain. And so when we tie that all together, I always think about J. Marion Sims, and he operated on enslaved women, in particular three, Anarcha, Lucy, and Betsy. And J. Marion Sims is lauded as the father of gynecology. And while that can be true that some of his research has afforded us with things such as the speculum, we can also say it was true that he was experimenting on enslaved women and that the bodies of Black and brown women wasn't valued, right? And so he was one of the first people, or some of the first people or medical providers who documented that Black women could withstand X amount of pain. Now, while that story might not have been told to providers present day, I always think of it as something like a scar or a residue, an idea that that is true, that continues to get passed through to different providers, including providers of color. So even if you share the same identity as someone, doesn't necessarily mean that you would have a mindset and a concept about anti-Blackness, racism, or oppression because you've been ingrained in that same ideology as well. So a lot of things that we learn about ourselves was given to us. It's not something that we ourselves learn or really think about ourselves. So tying it back to racism as a way, this idea and this power dynamic has been embedded in systems of care for years, and then it shows up present day to Serena Williams giving birth, complaining of pain and discomfort, knowing her body, and even though she's Serena Williams, not being trusted enough to know what she's feeling in her body and having to demand to be seen and to get an ultrasound, which actually showed that she had a blood clot. Think about that from the early 1800s moving into 2020. That just seems unfathomable, but it's the reality of how racism still has a residue and thread and exists in our country and all over the world, right?
Absolutely. But like, similar to like a Ford F-150, for example, just because that type of car can probably take more of an impact in a car collision than a Mini Cooper, doesn't mean that you're just driving recklessly or just driving without any care in the world, driving down the highway. Same type of concept
Yep.
for, healthcare systems. I'm not saying or agreeing that, the misconception that Black women can take more pain than a white woman is true. But even if that was true, that doesn't mean that you should be careless with them if they come to receive help. Like, why?
And I love that you said that example. I wanted to jump in here and thinking about the analogy you use with the car. So whether it's, what is it, a Ford 150 or F-150 or Mini Cooper, the care should be equitable. And equity means that, so let's say, now I'm making this up because I definitely don't know about cars, but if that Ford can go 1,000 miles without any checkup, right, and still run properly, and that Mini Cooper can only do 100, that means you need, which is health equity, means giving people what they need. So that means you need to ensure that at 100 miles, there's certain things happen with this Mini Cooper. At 1,000, although they're not the same, but they have needs, everybody's needs need to be met. So we need to have the access to care. So if I need certain types of care, I should have access to it. If this person doesn't take anything from them, they just don't need it. It might be available to them, but they don't need it. If you think about like how we even do with around social justice. You know, there's opportunities that some people need because they didn't have a fair opportunity in the beginning. Doesn't take anything from someone else, because you don't need that opportunity. You already have a different leg up, so to speak, in the world, that you don't need to have this available to you. It's for those who need it.
Interesting. Now, you don't think that there's like a lack of medication out there to, I guess, help everybody? Do you think that they are, or health administrators are holding on to, I guess, certain medications that are needed for certain procedures and using it for particular people? Like,
I, I don't know if I would say that. I would say two things. I think that the research shows that there is more, or the research conducted, let's say for medications, might be conducted on a population that may have a need. And I'll use PrEP, for example, because, you know, my background is in sexual health. So PrEP is pre-exposure prophylaxis for the prevention of HIV. When it started being researched, it was primarily research on cisgender men. And so there were very few women, if at all, involved in this research. So PrEP became a tool for prevention primarily for men, and not even trans men or trans women. And then it started being more available in research on trans women. What we could see is that there was still a need for HIV prevention in communities of color, in particular, also Black women. If we think about rates, it wasn't until a few years later that the research caught up with the need, but the need was already there. So now you see a lot more programming, a lot more advertisements in the communities of color, and particularly really focused on Black trans women and Black cis women. And so I don't think that it's necessarily being given to and withheld from per se. I think that that system that we're talking about doesn't allow us to say, if we have this medication, let's look at the research for the whole group at the same time. There shouldn't be a lag in the amount of time that it takes for one group to have access to a prevention technology than another. The same would be true in terms of, if I think about pain, going back to pain, oftentimes, and I've seen this in my personal life with friends and relatives, that when they experience pain, because they're a Black woman or a person of color, that the pain medication might be prescribed differently, or exercise, you know, the counseling differently because they're a person of color. They're still experiencing pain. Pain is pain, and people should have access to that. But there's this idea of not needing it and abusing it because of stereotypical ideas and stigma in our community.
interesting. And just honing in on that word equity, you know, healthcare for all, you know, everybody should receive the proper and needful healthcare. How do we tackle the people who are, you know, disconnected from the healthcare system? So I'm talking about, you know, homeless people, immigrants, ex-offenders, you know, the unreachable. You know, by the time these individuals receive or reach a healthcare professional, they have been suffering with severe chronic conditions for years, and it could cost, you know, these individuals up to millions of dollars to fix a problem that they had no way of receiving help.
I think a few things need to happen. There's a concept called health equity in all policies. So if we think about the unhoused, if we think about individuals who might be in active use for substances, or even have a mental illness or mental health diagnosis, just using those as an example, and a lot of times some people might call a dual or triple diagnosis, like the person who is unhoused might be in active use and may also have a mental illness diagnosis. But I think about that in terms of equity in all policies. So we know that if we look across different areas, if we look at housing, if we look at education, if we look at finance, even if we look at the judicial system, if we look at, I'm trying to think, even like child health or early education, early childhood education, we can see gaps and differences in graduation rates, education. We can see the number of people who are incarcerated and have greater times based on their offenses. We can look at the number of people who are at a certain economical status and see that there are differences all across those places. So what we have to do, health equity is just but one part. We need equity in all policies. We need equity in housing. We need equity in financial and in education. So it's not gonna be enough just to address what's happening in medical and healthcare. We have to address what's happening in the judicial system, in the education system, child welfare, and early childhood education, all combined together.
And in your opinion, how has the progress of that been going? Has that been going smoothly? Has it been stagnant, rocky?
I think that it's been ebbs and flows. I think people have sat down, and I'm only can really speak for North Carolina and some of the other states that have been examples for North Carolina. The idea and the concept of health equity in all policies has been well received in North Carolina. But I think as we look at laws and challenges, like even with our reproductive health laws and access to abortion and other family planning services, cuts in funding, we can have those conversations, we can move forward, but it takes but one policy to kind of put a pause on that or cut short what something that could have been great and accessible to everyone. When we think about laws that discriminate against people of trans identities or queer communities, that's still not health equity. So it means everybody, regardless of who they are, would have access to the education. A lot of things that happen even around these conversations about intersectionality, critical race theory, even equity and inclusion have been cut short because there's this idea of a power imbalance or truth creating a power imbalance. And so that's what has caused a lot of this to kind of like pause. I know in our state, that there was some education opportunities that people were having access to more education, learning more about the historical context of our state in the US. When certain policies were put in place, that meant certain topics couldn't be talked about. And even professionals in our state couldn't get the training that will allow them to address their implicit bias and maybe their internal racism or institutional racism within their organizations.
Interesting. And that's pretty prevalent throughout the country.
It is.
Wow.
More states, some states are more restrictive than others. I won't name them, you probably already know, but just thinking about the governmental limitations or ensuring that if we're looking at health equity in all policies, that could actually come to pass. But when you're hindered in these different systems because of policy, how are we ever gonna get there?
Yeah. Yeah, so I'm just being honest, do you think that this is realistic?
Sometimes, like in doing this work, I'm thinking, I'm talking about conversations about racial equity, social justice, health equity. I have these moments, especially as a Black woman, someone who transitioned from urban Brooklyn, New York, Bed-Stuy, to rural North Carolina, looking at the health conditions of friends and family and community, then serving as a public health worker, doing this work. I have these moments of doubt and concern that my work and the work of my peers and colleagues is really not gonna make a difference. But I do have hope. I do believe that there are people working in places, whether it's our legislatures, whether it's our leaders in different areas in these systems, who have a commitment just like I do to make it come to pass. Is it gonna happen overnight? No. And I'm often tell folks, if you don't have the hope, that your work is going to make a difference? How can you have the hope that it's ever going to happen? Because we're all part of that work. So that's what we're hoping, well, I'm hoping to do as an individual is like, I want to do my part. I want to find people who are just as committed as I am so that we have a collective impact. Even the language around collective impact, in previous years, people were using that because we knew that if different people, different organizations, different communities came together, that there would be a collective impact that would exact change in their communities, hopefully in our systems.
Interesting. So do you have a track record or any, yeah, I guess a track record of like policies that either you or people that you work with that have been instilled that has shown like some sort of progress in the right direction?
Absolutely. In some of my previous work, working with some local health departments here in North Carolina, right before the pandemic especially, we were working with some health departments. We were providing them training. We were trying to show them, just like we were talking about that historical context, because a lot of times when you talk to people about health equity and even about racism, it's like this far thing, right? Like, oh, that was so long ago, et cetera. But what they don't see is that impact that it's having present day. So working with these health departments, one of the trainings that we provided was just to give a historical purview of what just random, I don't want to say random, but like very specific actually impacts or times in history, whether it was a policy development, whether it was a tragic incident that still shows up in their work today. And the importance of looking at their hiring practices, looking at their orientation, and how they're bringing people into their organization and their organizational infrastructure, even their organization's vision and mission, to see if it was true to advancing health equity. So I worked with like 5 local health departments, and all of them moved the needle forward. But I remember 2 of them specifically digging deep and working with their leadership, having the buy-in, because that was the other thing. They needed the buy-in and the support of their leadership, not just in their organization or their health department, their county commissioners, the full organization, or the full community as a whole. And they were able to make some changes in some policies that are still existing today.
I hope you've enjoyed today's conversation topic so far, and 1, have a better understanding as to why the subject of health equity is an important one and it affects all of us, and 2, why health equity should be important to you. Hopefully you are inspired and or motivated to share this topic with somebody else so that they can feel the same way. Please don't forget to like, comment, and subscribe. And now for a short commercial break.
What if I told you you were one step away from building a legacy? In today's market, being seen and heard is tougher than ever, especially for Black-owned businesses. Forge a new path with YAM. It's not just a marketplace, it's a community where your story is amplified. Here you will build lasting partnerships, unlock new revenue, expand your reach, and grow as we grow. Leverage our free marketing and share your journey on our blog and socials. Be part of something bigger. Join YAM today and turn your business into a legacy.
Okay. Just correct me if I'm wrong. I'm speaking for myself and the people watching. So policies exist up until, I guess, somebody new comes in and says, okay, we're changing this?
Yeah, when you look at policies, like there could be a simple, like, so some policies are within the organization. So it doesn't take literally an act of Congress, but some of them are like, this is what our policy is in terms of intake. So I'll give you another example in terms of even using data to ensure that we know what health equity looks like and where the gaps are. So some agencies may not collect what you might hear people call SOGI data, which is sexual orientation and gender identity, demographic information. So you might have a form that has maybe 3 options when it comes to your gender: male, female, maybe not even 3. I'm just gonna say male and female. But if somebody doesn't identify, maybe they're non-binary, maybe they're transgender, right? And they want to indicate that. We can't always go back and look at LGBTQ data based on orientation, based on gender identity, to say where health gaps exist, because it's not collected universally. So a policy could be at a local level that on our intake forms, we're going to collect that type of data. Now, maybe that will funnel up to the state system. So now the state system may look and say, oh, you know what? They have this data locally. We may need to collect this, which they do, collect this data so we can see where gaps exist on the state level, which would go up to the federal level. And so the only way we're going to have that is if everyone comes to collecting that type of specific data. So then we can have reports. If you look at the research, there are very few opportunities where you can get data to look at other issues beyond sexual issues for persons who might be queer or LGBTQIA identity. So that's an example. Now, from the federal level, you might say that perhaps Congress will pass a law that says, from now on, every health department, every hospital must collect this data. We haven't gotten there yet, but that could be something that once that's done is definitely, so it's either gonna be, trickling up to say this is what we need, or there could be a mandate and it definitely trickles down. We wait for the trickle down, we may not ever see it happen. So that's why organizations have to take the lead on doing the health equity work themselves and serve as examples.
Interesting. So you just mentioned in your example that Congress, we're not there yet with Congress with regards to requiring that everybody denotes their gender and race.
Sexual orientation as well, yeah.
Why? Because I feel like that's just like a checkbox on a piece of paper. Like, why would that be such a big deal to add or not add? Like, you're just typing an additional line.
You would think it would be that simple, but it's like, it's so complicated in the sense of like what policies on the federal level can govern. So like hospitals have their own authorization and places where regulations that they have to follow. Local health departments have theirs. I personally feel like, as someone who's worked in the state health department and a local health department, if we could get it at least for the Centers for Disease Control and other national organizations, that will show up in local health departments and in the state health department. And it would only cause private organizations like hospitals to follow suit if they're not already doing it. But I think there's also this idea of like, who actually needs the services. It goes back to that reason why we don't have health equity. There's a power dynamic. Socially, if you think about the wheel of oppression and social dynamics, we know that people of marginalized identities, so different races, so people of color, people with limited ability, persons who identify as LGBTQIA, are lower in that power wheel and that power dynamic. So if it's not important to you, if you don't identify in that way, then why would you push these measures or a way to collect this data? Because it doesn't have an impact on you. It also doesn't have an impact on you, not only because it's not your identity, but you're not the one who might be impacted by health concerns, because again, that's not your community.
I hear you, but me personally, that's not how I would lead.
Yeah.
You don't lead based off of what works for you personally.
Right.
You lead based off of what works for everybody.
That's what we elected them for, right? They're supposed to be the voice for everyone, but you see that doesn't always happen.
Clearly. So my next question would be, what would you propose for America with regards to health equity? Everybody receiving the same health equity or health care. regardless of religion, sexual orientation, gender. You know, what would, if you had all the power that at B and you didn't have to report to anybody or you didn't have to, you know, receive any type of approval, what would that look like for you? Like, what would you do? Seeing, like, you know, all of the problems that hospitals are facing and, you know, people of color are facing, and I'm sure, you know, you have a wealth of experience. So what would that look like for you?
That's a tough question because as we were preparing for this, I actually saw one of my old professors come through and I recalled, and I was thinking about this. Um, it was in the 90s. I want to say it was 95, maybe 94. And I remember then President Clinton, or maybe he was actually running for president, but I can't remember. But I know he was talking about health care for everybody. And the conversation was about universal health care, so to speak, but he just couldn't get it together. And you might even remember that as we were thinking about the Affordable Care Act and like what that looked like years ago and like moving it forward. And we do have that, so we've made strides in that way. And I'm trying to think like what I was thinking then, what I'm thinking about now, and all of it still seems to be the same, that we need to ensure that people have affordable health care, that they not only have access to the coverage, but then they have access to quality health care. So that means ensuring that communities of color, people of color, you remember we were talking about healthcare or health equity in all policies. You know, years ago, we had a cutoff. There were only 2 training schools for Black medical providers. What we need is an opportunity for individuals in communities of color to become trained, and that everyone is trained in a way to address their implicit bias, to address their own kind of like internal racism or internal biases, so that they can provide the best quality care. I mean, if you have a brain, you have bias, so it's gonna show up, but how do you adjust for that in your care? And how to be personable, have a good bedside manner. And this includes providers in hospitals, but it also includes our providers here in the local health departments, as well as in our federally qualified health centers. So everywhere. I think training, I think opportunity is important. Then I think we have to think about like capitalism is a thing. So why are certain meds inaccessible to certain communities for so long? But I know that we have big pharma, and then we have research, and then sometimes they're kind of connected together. So we also need to make sure that our research is actually extended to communities in a culturally appropriate way, so that communities of color feel comfortable participating in trials, so that we know what the medications can do for everybody, instead of like, that lag time. I don't know what that looks like. If I could wave a wand, all of that would be in place. And I think we probably would be able to address health equity, but we still need to think about what are those other systems, right? So ensuring that there's fairness and justice, there's fairness in education. Some places we know more and more we have more opportunities for people to go to college at an affordable rate, but it's not extended to everybody. And everybody, doesn't have to go to college, but the idea that it's not extended to me, I don't have access to it, I have to, get in debt just to do this, and then may not get a job because there's unfair hiring practices that still exist. So the wand that I probably would wave would not just be over healthcare, it would be all those other systems as well.
And it would require those other systems to be on board.
Absolutely.
Interesting. And when you say quality of healthcare,
Mhm.
do you mean pumping more money into hospitals? Like what
Yeah.
affects quality? Because I'm sure every hospital has a syringe. Every hospital has a
Yeah.
needle. I mean, I don't mean to sound ignorant.
Quality is also about how you're treated when you get there. So like when you walk in the door, are you already going to be stereotyped about a certain condition or treated a certain way just by the way you look? And then when you open your mouth, is that even going to be more, stigma placed on you if you share about your experiences in life? your opportunities? Are you going to be treated differently solely based on who you are? So quality is not just having access to those supplies and providers. It's about how you're treated when you're there. When you look around the room, do you see, like, if there's things on the wall, do you see yourself represented in this space, right? If you are someone whose English is not your first language, or you don't speak English at all, is the quality of that healthcare, meaning that someone is there or resources available for you to communicate effectively about what's going on in your health? That's the quality piece. It's not, it's about how you're treated as a human being. That's part of the quality. Can you even get there? I'm going back to health and all policies, but like, do you have to get up 2 hours, take a bus, and maybe walk to get it? Is there access in your geographic location to even have the health care? So that's the quality. Does it look different 10 miles from you? Do you prefer, like, I think about when I moved to North Carolina, the preference of my family was not to go to what was readily available within, not walking distance, but at least 20 miles from our house, a healthcare facility. We'd rather travel 30 to 45 miles to a different healthcare system.
Interesting. So customer service. Interesting. And that definitely does play, a huge role, especially if someone could be in a hospital bed dying and not being looked at properly.
One of my first experiences with understanding that was after graduating, having a job interview in one of our local health departments, feeling like I'm professional. I had on, a suit and walked in, and the way the person treated me at the front desk as an intake, I'm just telling her why I'm there and who I'm there for, was just different. And it made me wonder if I wanted to work there. And I did accept a job, and it was just interesting to have those conversations about how you treat people when they walk in. I wasn't there for care, but if I was, I probably wouldn't go back even after receiving care. And it made me even contemplate not taking a job there if I had, had a successful interview, which I did. But it made it, I'm glad I took the job. It was a great experience, but it allowed us to have conversations about how we treat people when they come to our agency.
Interesting. So my next question, it deals with customer service, it deals with quality. And we kind of touched upon it, but we didn't really speak on it deliberately.
Okay.
So there's a huge disparity when it comes to childbirth deaths between Black women and non-Black women, or non-Black or brown women. It's just so crazy to me, like, how could something so natural end up being so catastrophic? How do you suggest that we shrink that gap? Correct me if I'm wrong. I mean, my research shows that maternal deaths in America match that of a developing country. Please, how do you suggest that we tackle this issue when it comes to customer service and quality?
Yeah, I think it goes back to some of that historical aspects of, like, what did it look like to give birth? What opportunities or resources actually are available for women of color? And so just thinking it back to that. So there's still that level of oppression. In the 1900s, I think it was, the childbirth became more medicalized. Like, that's when more hospital, it was like you had midwives, right, back in the day, and then it became a more medical focus. And I think that's where some of the care change also just kind of got disproportionate. Like, it was more like it's this process of getting you in, getting you out, and the quality of care is going to change based on who you are specifically and where you get your care. So I think that is the biggest challenge, is that we have to think about more ways that we look at doulas, we look at midwives, and we look at the ways in which birthing people give birth. I think that's the biggest challenge. And while we have it's boggling to know that even when we move to a more medical model around birthing, we have all these advancements in technology that we still have these rates of death, not only for mothers with maternal mortality, but we still have infant mortality that we're still dealing with, although the numbers have decreased. And so I think that again, going back to those systems of care and the systems of operation, is that we need individuals to be more mindful, to listen to their patients. But we also need opportunities, that's why doulas are so great, is to also, I'm using the word empower, but I believe people already have power within, but to maybe, I'll say, educate and help motivate women to know the questions to ask and be able to assert and address things and have an advocate. A doula is a great advocate to have with them, even if you're in the hospital, so that you have advocacy, people who are trained and skilled beyond the mother. My sorority sister just had a baby the other day, actually yesterday, and I remembered throughout her pregnancy, I was so excited, but like, to be honest, in the back of my mind, I always had this like, oh my gosh, this is really scary. Like it was. And to see that, she gave birth yesterday morning, to see her and her holding her child, there was a level of relief, like, whew, she made it. But also there's still this thought of like, she has to make it to a certain point, right? Like the baby has to make it to 1 year old to not be considered, with infant mortality. And she has to make it almost a year herself without any complications as well. And so just thinking about that, I think we have to honor the medical model and the technologies that we have, but also honor having advocates like doulas being trained and utilized more openly.
So I have a couple questions. So when you say doula, is it the doula?
Just doula, D-O-A-U-L-A.
And what's the difference between a doula and a midwife, or are they synonymous?
So some people use them interchangeably. I think a midwife is someone who has a different qualification, like they can actually fully birth the baby, whereas a doula is someone who's more like a coach. Some of them are both, like they're midwives and doulas, but some doulas, they wouldn't necessarily, well, they might actually be able to deliver the baby, but they're there with the person who's delivering the baby and really a coach and a support for the mom while she's going. And she builds a relationship with the mom. So like she knows about her social support. She knows a lot about her health and health concerns. Like she's been with that person throughout their pregnancy. It's like the mom's best friend during the pregnancy who can be there in the birthing space and to share information and support the mom while she's delivering.
Interesting. And same goes with midwife?
Yeah, but a midwife is technically allowed to deliver a baby.
And that goes into my next question. Do you recommend or suggest home births versus hospital births with the numbers that we see with maternal deaths?
I really think it's a personal choice. I think that, especially if you have a doula, going to the hospital won't be as scary. We don't know what's going to happen. Like giving birth is definitely a very serious procedure and matter and situation. I think it has to be something that the person who's giving birth has to really reconcile, like where they want to do it. I don't think there's a one best over another. I think it's like, what do you want that experience to be for you? I think some people want a very warm, loving, less technological experience. And so home birth, we've seen them happen, is something that they would prefer. Whereas some folks are traditional, like if your mother gave birth to you in a hospital, then you're more likely to think that that might be something you would do. So I also think it's generational and cultural as well.
Interesting.
And some people don't know that's even an option, right? Like if you go to a traditional prenatal or parenting classes or, pregnancy classes, most of the time, traditionally, you're preparing for a visit at the hospital, not necessarily a home birth. And so it's something that kind of is socialized in us to think, if I become pregnant, that's the type of birth that I'm going to have. I might not have any other options.
Yeah, absolutely. Absolutely. And do you know the statistics off the top? It's okay if you don't. Off the
Yeah.
top of your head of maternal deaths from at-home births?
I don't know the statistics specifically, but I did remember going to a conference and hearing that it was lower. But a doula was actually present primarily, as well as the midwife or the person delivering.
Interesting.
Yeah.
And then you also brought up infant deaths
Mhm.
too. Are those as high as maternal deaths?
So infant deaths for women of color, Black women, and in general, specifically in North Carolina, well, in the U.S. has been really high. North Carolina has had some of the higher rates in the past. So one of the questions you asked me, and I want to circle back to it, was asking me about like health equity. Is it new? We used to use the term health disparity. We still use that because that means there's this gap in a situation, a health outcome from one population to another, and usually it's the white population. So in North Carolina, at one point we had, I think it was a rate of like 1 out of 7 births, so to speak, in North Carolina would result in infant mortality. So infant mortality means that after birth, a child doesn't make it to their first birthday. So we had sudden infant death syndrome and other complications around infant deaths. So we had programs that we use. One of them was really cute. It was called Stomach to Sleep, Back to Play. That was also a cultural shift too, because culturally, people would put their babies on their, their backs, and not on their backs, like on their stomachs, to sleep, and could also cause like suffocation. So with saying you put your baby on the back to play, making it like a rhyme would just help remind people of like how to place your child down to sleep, which would potentially reduce a death or something happening. So that took education, that took going into communities, that took also bringing in families, so around that generational conversation. So we had to see that. We also saw more expansion in education around prenatal care. So ensuring that persons who wanted to have babies or give birth were at the best health they could be in prior to becoming pregnant, so that they would also be in care early, so that when they became pregnant, they would have a consistent care as they went through their pregnancy, versus finding out you're pregnant maybe after your first trimester and then getting that care. So you think about like programs like the March of Dimes with folic acid to actually reduce birth defects, those kind of things. So all of that combined together in our state help reduce infant mortality drastically. Wow. Right. So I'm really proud of like knowing those people who worked on some of those programs throughout the state, and especially in Eastern North Carolina. So we know that those things can work. So yeah, that was another health equity issue that we're still dealing with.
Wow. Well, first and foremost, congratulations.
Yeah.
That's awesome that you were able to shrink that gap. Additionally, with what you just said, with regards to closing that disparity between Black women and non-Black women, you said a doula and a midwife would be apropos. Circling back to one of your responses as well, do you also believe that if more people of color, more Black doctors, nurses, health administrators, if they were working in a hospital as well, that would also shrink the disparity, or do you believe that there's more to that?
I think yes, and there's more to that, like, right? I think that we know representation matters. I think there are some individuals who definitely feel more comfortable seeing individuals in hospitals or clinics that look like them and have what we would consider culturally appropriate care, because they would be connected in some ways to the culture. That doesn't negate that those individuals, whether they're providers of color, wouldn't still need training, right? Remember, I said we all kind of were socialized in this racist ideology, whether it's internalized, and then we have the systems. So we still wouldn't say they wouldn't need training. They're going to get it right, because we all kind of carry a little bit of bias even about ourselves. So, but I think it's important to curtail the fear when you can provide a provider, when there's a provider available who actually understands cultural nuances of individuals that look like them. I think that is very important. I think on the other hand, in addition to that, white providers also need that training, and they need to work together in concert so that hopefully it wouldn't matter who your provider is, that you're gonna know that you're gonna get that quality care at some point.
Wow, you took my next question right out of my mouth. But with regards to the training, I was going to say, well, specifically for non-Black and brown people, if they needed special training, not only at the job or on site, but also within their education.
Yes.
Before they graduated and before they started working in hospitals and working with patients.
Yeah.
Like, do you believe that there should be like special courses that universities should roll out for non-Black and brown people if they want to work in a public hospital?
Absolutely. I think our providers need more preparation, and shout out to any MD, having finished a PhD. I know being in school that length of time is a lot of work, but I think it doesn't have to extend their schooling. I think it has to complement their schooling. I think, I'll again use another sexual health example. So some providers aren't well versed in serving and being culturally attuned to persons with LGBTQ identities or issues around even sexuality. Most providers get less than 20 hours of preparation prior to practicing on sexual health issues, whether it's about understanding LGBTQ issues, sexuality and cancer, just various aspects of sexuality. And so if you're thinking about a whole person, and then you're not getting even information about managing your bias, you combine that to a person who might be a person of color who also identifies as LGBTQIA, who may now have a cancer diagnosis that's impacting their libido. How well is that provider going to care for them when their preparation and training hasn't equipped them to fully address the needs of that patient that's sitting before them? So we need to look at ways that we can implement various aspects of understanding bias, dealing with personal issues in the training that MDs or any provider, whether it's human service, whether it's medical or healthcare, to ensure that they can do quality care and also assess themselves. Like, how often do providers become assessed on how they treat a patient or their own, addressing their biases? So self-assessment and peer assessment also would be beneficial.
How would you recommend that assessment be rolled out? Like, would you recommend health officials or health administrators from hospital A go to hospital B and they spend a day there and then they watch them and the same thing goes? Or do you think the state should send somebody to every hospital? What would make sense to you?
I think a peer evaluation would be good, and a mixed peer evaluation, ensuring that there are providers of color. So it's not just your peers who look like you, but looking at things that you might miss. The other day I was talking to a loved one who went for a follow-up appointment, and even their training. So sometimes you go to a provider and there might be a student who's learning and shadowing the provider. And my loved one told me that the provider texted twice and took 2 phone calls while they were in the room in front of the person that they were training. And so my loved one spoke up. Somebody else might not speak up. Perhaps the the student trainer was aware of what was happening, maybe not, and maybe the provider thought, my loved one felt like because they were a person of color, a Black person, that the provider was treating them that way with a racist undertone, that they felt like they would have not taken these calls or sent those text messages if they had been white. We don't even know if that's true or not, but as a person of color, you can only assume that that hasn't happened to me before. Why is this happening now? And so I think peers need to evaluate each other, as well as whether it's some hospital regulation or state regulation, whether and do your own self-assessment, like periodically look at how your I'm going to use bedside manner or patient care. You use the word customer service. How is that happening? How are you writing your notes? Because that's the other thing where we see racism and discrimination show up, is even the way some providers have written their notes about what they said about a patient was definitely an undertone of racism and discrimination in their notes.
Interesting. And I haven't been to a hospital in a very long time. Um, is similar to like if I were to call Delta, for example, how they say, after this call, rate us from one to 5. Do doctors have that? Like, if I go to the hospital for whatever condition, is there a sheet that says, rate your experience 1 to 5?
Most providers have that, local health departments, some private physicians, and hospitals.
Okay.
The key is, what do you do after that? So like a deeper assessment too, right? So that's why I say there needs to be a supervisory evaluation, a peer assessment, and a self-assessment, and those satisfaction. Because typically after you go somewhere, like I just went to get a massage and I got, like, tell us about your experience. And as consumers and patients, we need to give that feedback and as much as possible, especially like I know my loved one is going to follow up with that healthcare facility because it really was rude and inappropriate during that time. It was a serious, follow-up appointment. And so all of us have to play a role. So we don't know what happens after we fill it out, but I think it's our responsibility to fill it out.
Interesting.
Yeah.
Well, I believe that we've reached the end of the episode, but before we end formally, do you have any lasting words that you would like to get off your chest or say to the audience with regarding health equity, with regarding NC SexCon? I mean, anything
Yeah.
in regards to your brand that you want to promote?
Absolutely. I'm so glad that you would have me here. I'm definitely committed to health equity. I think we all have to play a part in advancing health equity. I'm super excited. I started the North Carolina Sexual Health Conference in 2016. So we're gearing up for 2024 in Raleigh in September 2024. And we really want to focus on different aspects of sexual health equity and reproductive health and policy. So we can't say who exactly, but we're lining up folks that we can really talk about issues around sexuality, whether it's looking at young adults, we're looking at individuals in the trans experience. And so we're really excited about that. And hopefully more to come on when the conference will be and the dates.
Absolutely. Well, thank you so much. It was truly a pleasure speaking with you and meeting you. I believe that today's episode has so much information, so much perspective, so much insight from you. I enjoyed speaking with you. I'm sure that our viewers are going to enjoy listening. It was truly a pleasure, and I hope this year's NC SexCon goes wonderfully, and I'll be looking forward to hearing more about you.
All right. Thank you.
So we've reached the end of today's episode, and I hope you've enjoyed today's conversation topic. Please don't forget to like, comment, and subscribe, and I'll see you in the next episode. Bye.